Hi, I'm Dorcas Lomo. I'm one of the fellows here at CVR. Thank you so much for having me here this morning. So this is Dr. Pappas's patient. She is a 43-year-old female with a history of G3, P3, and depression who presents complaining of bilateral swelling, heaviness, and restless legs for many years. Symptoms include tired, heavy, and achy legs that worsens throughout the day, aggravated by prolonged standing and improved with leg elevation. She has worn compression stockings for 8 years and noticed that her symptoms just worsen for the past years. Past medical history as above, past surgical history, tonsillectomy, medications included acyclovir, Mirena, and Ativan. Social history was negative for tobacco or alcohol use, and the patient is a housewife. Her SEEP was 3 bilaterally, and her RVCSS scale was 10 bilaterally. So on physical exam, there was 2+ bilateral pitting edema with varicosities noted in the medial aspect of the mid-thigh extending down to the distal calf. On duplex ultrasound, there was reflux from junction to prox calf and at distal calf of the GSV on the right. On the left, reflux was noted from prox thigh to distal calf of the GSV on the left. The GSV was tortuous on the left from the mid-thigh to the mid-calf. There were multiple tributaries noted bilaterally from mid-thigh to distal calf. As you can see, if you can definitely appreciate that the diameters of the vessels were larger than 10 millimeters in certain sections, especially on the left, it was extending from junction to above knee. These are important factors that we should definitely consider while creating the treatment plan for our patients. So the initial treatment plan for this patient, we started with the right. There was a GSV of the RF of the right GSV with USG of the below knee GSV. And then we went ahead and proceeded with the right 10 to 20 microstaph phlebectomy. Then the left, there was a GSV varithena due to the tortuosity of the vein. And then there was a 10 to 20 microstaph phlebectomy with a varithena done on the left for the multiple tributaries. During her 1-month follow-up, we can definitely appreciate improvement in the appearance of her legs bilaterally, but then there was still reflux present. And the patient had denied any symptoms of the left leg. So we continued to treat the right leg since she was still complaining of pain and swelling. We initiated a laser ablation after the RF of the right leg with a USG below knee GSV. And we went ahead and treated the remaining tributaries of the right with varithena as well. So the patient stated that her restless leg symptoms had improved at the second 1-month follow-up, but she continued to complain of persistent swelling in both legs, and now the left leg was now symptomatic. So the patient was scheduled for an RF of the left GSV with USG below knee GSV. So although this patient failed multiple treatments, it is important to understand recurrence and factors that contribute to recanalization. I will discuss multiple different studies that provide insight about these factors that we come across on a daily basis in our clinic setting. And I believe it can also be educational for the patients as well. So this study was by Zoman et al. They attempted to provide an objective scheme for the definition and classification of recurrence after endovenous thermal ablation. The study also describes the type and rates of recurrence after endovenous thermal ablation, as well as factors associated with recurrence. There were a total of 449 patients who were recruited from a patient cohort of 1,673 patients from a previously published study. Within the study, they identified definition of recurrence after endovenous therapy. For varicose veins, they defined it as a subcutaneous permanently dilated vein 3 millimeters or larger in diameter when the patient was in a standing position. And this was according to the International Union of Phlebology guidelines. They define recurrence by referring to the REVAS study on the basis of the presence of varicose veins in the lower limb that previously underwent varicose vein surgery. And then a recanalization in the SFJ area was considered a recurrence if the length was greater than 5 centimeters. The term neovascular was used to describe newly formed thin tortuous veins in the vicinity of the SFJ. They distinguish between neovascular vessels running inside and outside the compartment of the GSV. In regards to recurrence types, they focused on the anatomic classification by creating 3 different categories shown here in table 4. A was recurrence in the area of the SFJ, B was recurrence distal to the SFJ, and then C was newly occurring varicose veins independent of the treated region. So among all the recurrence cases, 9% showed a recanalization of the treated vein in the SFJ region, primarily affecting the GSV. And then the largest recurrence group was the neovascular vessels in the region of the SFJ in 57.7% of the patients. In 85% of the patients, there was only 1 type of recurrence, and then 2 types of recurrence were found in 13% of patients. And then only 2 patients had 3 types of recurrence. So with this, they concluded that different recurrence rates occur depending on the definition of recurrence, right? So if every new varicose vein that occurs post-op is described as a recurrence, a rate of almost 54% would result. However, if only new varicose veins associated within the treated region were considered, the recurrence rate would decrease. Therefore, they went back to the drawing board and they tried to avoid misunderstanding. So they recommended a precise description of the definition and classification of recurrence. They modified their understanding of recurrence to include only recanalization and neovascularization, because all other newly occurring varicose veins might also have developed as a result of the progressive course of the patient's disease. So in A, the failure of surgical method included recanalization in the area of the SFJ or distal to the treated veins. And then B, it describes the neovascular vessels as an independent group because although they are associated with the operation, they also show disease progression and are not solely due to the failure of the surgical method. And then C indicated the progression of the disease, which includes reflux in untreated vessels, perforator insufficiency, and new varicose veins occurring outside of the treated region. So with this modified classification in Table 7, Group A showed a 11.6% recanalization risk, whereas Group B and Group C had similar frequencies. Overall, they found that recanalization risk of the GSV was low after 3 years. So now that we know that neovascular vessels and recanalization are classified as recurrence, we also should consider factors that contribute to recurrence, such as age, gender, BMI, the vein diameter, the modality of the treatment used, the target veins, risk factors, clinical class, the laser wavelength matters, and then the laser energy also matters. So these are all the factors that we need to consider to understand the risk of recurrence. There are several articles that study these factors, and I will delve into a few of these articles to give us a little bit more insight. So this study was by Dorcas et al. The goal was to establish the incidence of early recanalization after laser treatment and to also study the histopathologic features of reperfused and excised GSV. There were 109 GSVs and 85 consecutive patients were treated for the laser ablation. However, during the 12-month follow-up, only 104 treated veins of 82 patients were able to present for interval regular duplex scanning. But what they did find was that early recanalization requiring treatment was observed in less than 10% of GSV after laser ablation. Therefore, 90% of the treated GSVs remain closed after 12 months post-op. Now, is there a difference between RF and laser recanalization? So Arshina et al., they considered this question in this retrospective study. They used RF was performed in 1,027 patients, and then laser was performed in 448 patients. The target veins included the GSV, the SSV, the accessory saphenous vein, and the perforator vein. At 1 year, accessory veins demonstrated twice the recurrence rate compared to the GSV and SSV, and the perforator vein had almost 5 times the recurrence rate. Excluding the perforator veins, they noted that there was no difference with recurrence rate between the RF and the laser at 1 week and 1 year follow-up. But in all their data, they suggested that there was a low overall recanalization rate after ablation of the GSV and SSV. They also briefly touched upon gender as well, if there was a correlation in regards to recanalization. For this study, 1475 procedures were performed, 539 were males and 936 were females. Females had a higher failure rate of obliteration than males per the authors, but they did indicate that further studies needed to be considered for sure. And then what about recanalization rate of specific target veins? So as I mentioned earlier, at 1 year, the accessory veins demonstrated twice the recurrence rate compared to the GSV and SSV, and the perforator vein had almost 5 times the recurrence rate. Therefore, recanalization rate is less in the GSV and the SSV targeted veins. And then, are there any recanalization associated with comorbidities like diabetes, hypertension? So Bunnell et al.'s goal was to identify risk factors for saphenous recanalization after a successful RF. This was also a retrospective study. The patient population showed a GSV recanalization rate of 6.8% over a 6-month follow-up period. In the patients with recanalization in the study, there was no statistical evidence that the comorbidities listed on table 2 behaved as clinical risk factors of recanalization itself. And then the Ravada study, this was a very interesting study published by Bush et al. The overall goal of the study was to determine the site, the source, and contributory factors of varicose vein recurrence after radiofrequency ablation and laser ablation. And it was a retrospective study. 7 centers enrolled their patients into the study over a period of 1 year. There were 164 were identified as having recurrent venous disease after previous thermal ablation, and these patients formed the basis of the study. There was a comparison between the use of RF versus laser and whether there was a significant difference in the rate of recanalization. RF was performed in 33 patients and laser in 131 patients. In regards to recanalization rate of RF versus laser, the study noted a significant difference was found between both modalities. The recanalization probability was 10 times more likely with the RF as opposed to a laser with a 1320 nanometer wavelength. And then the recanalization probability was 7.2 times more likely with RF as opposed to laser with 940 nanometer wavelength, and then 2 times more likely with RF as opposed to laser with 810 nanometer wavelength. But the author did indicate that the RF used in the study was an older generation device. Therefore, that may be why there was a significant difference noted. The previous study I mentioned utilized the newer generation devices in which we did not appreciate, or they did not appreciate, any significant difference in recanalization rate between the RF versus the laser. They also compared the wavelength as well. So only the 940, the 810, and the 1320 nanometer lasers had sufficient numbers for statistical analysis. Therefore, they utilized these wavelengths. They subdivided the laser ablations into types of laser utilized, with over 50% performed with the 940 nanometer wavelength. So the average energy in the 1320 nanometer group was 100 joules per centimeter. The energy in the 940 nanometer group averaged at 80 joules per centimeter. And then the laser with the most failure was the 810 nanometer wavelength. They noted that 3 of the thermal ablation failures occurred in patients with less than 60 joules per centimeters of energy. But overall, decreased wavelength and energy has been reported to be a factor in the failure of thermal ablation, which is why it's important to develop a follow-up protocol for repeat ultrasound after thermal ablation. So the authors had recommended follow-up period 2 to 3 days, post-op, 1 month, 6 months, and 1 year, with the hopes that this protocol would allow the early identification of persistent or new reflux in perforating veins. If identified, we can definitely go ahead and initiate treatment. And then Van der Velden et al. Study was a randomized controlled trial from 15 different studies from around the world. The objective was to identify predictors to develop and validate a prognostic model of recanalization of the GSV in patients treated with endovenous thermal ablation. 1,226 legs were included in the anatomical cohort. The result at 1 year, 130 GSVs were recanalized. Clinical class C3 to C6 and diameter 6 millimeter versus 8 millimeters of the GSV were the strongest predictors of recanalization. So in all, they concluded that recanalization of the GSV was reported in up to 10% of patients after 1 year. But then they also stated that legs with C3 to C6 disease had 2 to 3 times higher odds of developing recanalization compared to legs with C2 disease. And then what about recanalization risk with BMI greater than 30?
In a quarter mile, keep right at the fork to stay on I-80 East.
Dr. Pappas, I think you're...
George Washington.
Yeah, that's me. I'm sorry.
It's fine. So the initial thoughts of this study by Ahmad et al. Was that chronic venous insufficiency had an increased prevalence among obese individuals with a BMI greater than 30. Therefore, the question was, does BMI predict the chance of developing recanalization? Out of 10,000 ablations performed, the mean BMI for this study was 32. There was a total of 207 recanalization noted. They proceeded with the multivariate statistical analysis, which was used to differentiate any difference in BMI and recanalization after ablation. They found that the mean BMI of patients experiencing recanalization was 33.3, and the mean BMI of those who did not experience recanalization was 32. They concluded that obese patients did not experience higher recanalization compared with non-obese patients after ablations. They did indicate that further research should include other weight parameters such as waist circumference, waist to hip ratio. And there were other articles that also concluded the same significance, that obesity was not a factor in an increase in the risk of recanalization. And then what about recanalization risk with age, especially in older individuals? So as we all know, chronic venous insufficiency has an increased prevalence among older individuals, but it is also important to know if age is an independent risk factor for recanalization following an ablation. So this study was by Al-Sheikh et al. They performed endovenous ablation from 2013 to 2018 on 3,075 patients. There was significantly more recanalization in older patients with an average age of 68.1 years. A secondary analysis was performed with the exclusion of perforator veins, especially due to their 5 times increased risk of recanalization. And it still showed that there was an increased rate of recanalization in older patients. And then, is there a recanalization risk with increased energy? Probestal et al., their objective was to analyze the influence of increased energy dosing on immediate occlusion and recanalization rate after a laser ablation of the GSV. So the GSV were treated with either the 15 watt or the 30 watt of laser power by using the 940 nanometer diode laser. And there were a total of 114 GSVs that were treated with 15 watt, and then 149 GSVs were treated with the 30 watt. With the laser ablation at the 15 watt, an average lead of 23.6 joules per centimeters of vein diameter was delivered. The max was 30 in regards to the lead. With the laser ablation at 30 watt and a reduced pullback velocity, an average lead of 69.9 joules per centimeters of vein was administered. So in conclusion, what they found was that the higher dosing of laser energy shows a 100% immediate success rate and a significantly reduced recanalization rate during the 12-month follow-up. And then lastly, what about the diameter? Is there any specific recanalization risk with diameters? So more recanalization was observed in this study with a GSV diameter larger than 10 millimeters. They did appreciate that there was a statistical significance noted. Regardless of the type of method used, the GSV diameter is a predictor of recanalization, especially when the diameter is greater than 10 millimeters. So for this patient, when she came back for her third 1 month follow-up, the patient indicated that her left leg was now symptomatic. So we scheduled her for a venous sale of the left GSV. And then she came back the fourth and fifth month for her 1 month follow-up. The left GSV was retreated with Varithena, and then the right was retreated with, the right GSV was retreated with Venacil. The patient finally reported that her symptoms had improved and the duplex confirmed occlusion of the GSV bilaterally. Given the large diameter of the GSV on the right, maybe RF wasn't the ideal technology to use. And then for the left, due to the tortuosity of her GSV, the only option at the time was the foam injection versus stripping. So in conclusion, age does make a difference in after ablation as a treatment for chronic venous insufficiency, especially if we have older individuals, because there's an increased risk of recanalization if it's performed in an older patient. In regards to gender, gender might play a role, but there wasn't sufficient studies that indicated that there was a role in regards to gender. For BMI greater than 30 does not predict the chances of developing recanalization. For vein diameter, increased risk of recanalization with vein diameter greater than 10 millimeter has been noted. And then laser and RF recanalization risk less than 10% after 12 months is statistically significant. GSV and SSV has less recanalization rate compared to the accessory saphenous vein and the perforated vein. And also remember that there is a 2 times recurrence rate with the accessory saphenous vein and 5 times recurrence rate with the perforated veins. Comorbidities, there was no significant difference in the risk of recanalization with diabetes, hypertension, heart failure. And then C3 to C6 disease had 2 to 3 times higher odds of developing recanalization compared to legs with a C2 disease. And then decreased wavelength and late energy has been reported to be a factor in the failure of thermal ablation. And so that's it for this presentation.
So that was great, Dorcas. I just want to say, compared to when you first started doing these presentations to now, what a phenomenal improvement in your knowledge and your confidence in your presentation. That was a really great review of, recurrence and failure rates. So does anybody have any questions
In a quarter mile,
for
take
Dr.
exit
Lomo?
71 toward Englewood.
So I just want to say that case that Dorcas presented was very, very frustrating for me because as you can see from her presentation, this patient had every risk factor, for a failure. So it was very, very frustrating. Although I have to say the patient was great, but it was very difficult trying to treat this lady. And going back and looking, at what I would have done differently. I don't know what I would have done differently in this case, except maybe instead of starting with the RF, start with the laser. But the current recommendation is if RF fails, you go to laser. If laser fails, then you go to the other technologies. The really frustrating thing was the tortuous left saphenous vein, which I knew was not going to do well with the Verithena on the first try. And I even told the patient that there'd be a likelihood of failure on that patient on that left side. But anyway, any questions from the audience for Dr. Lomo? All right. So if not, then have a great weekend, everybody.